I heard everything but couldn't move. I thought I was dying. Terrified. I was very scared. I thought I will be paralyzed and unable to move. It was really a bad experience. I thought to myself, oh no, I am going to be awake and feel the surgery happening. Being alive only in the head.
Hello everyone. Welcome back to my podcast. This is your anaesthetist. Today we are going to talk about the issue of am I going to wake up in the middle of my operation? Now, some people who are about to have a general anesthetic worry about the fear of waking up in the middle of their surgery. Is this possible? Well, can it happen to you? In this episode, I will try and help you make sense of this fear, help you understand how unlikely this is, and some specific circumstances where it has happened in the past and where there might be a higher chance that something like this could happen. Although, once again, it's very, very unlikely that something like this happens to you. Keep watching. Let's begin with the question. Does it happen? And can you wake up in the middle of your operation? Well, the simple answer is yes, it does sometimes happen. But is it common? Quite simply, the short answer is no. It's not common at all. In 2015, the Royal College of Anaesthetists in the United Kingdom conducted a nationwide study in the UK and Ireland. It had a sample size of 2.8 million patients, and that is the total number of patients that had a general anaesthetic for any kind of surgery in all of United Kingdom. They found that the incidence or the number of times they found accidental or patients had accidental awareness under general anesthesia was to the tune of 1 in 20,000 operations. So, in other words, you extrapolated this, of every 100,000 patients who had a general anesthetic, 5 experienced it. So, the other 995 patients did not experience it. So, it's an extremely unlikely thing to happen. But more specifically, why does it happen? Surely all anaesthetists are well-trained and highly vigilant people. Surely there's enough monitoring and technology going around to keep an eye on the patient. Surely no one intends this to happen. So why does it happen? Well, let's look at a case written about in NAP 5, and hopefully I can use this to illustrate what sort of factors go on behind the scenes which lead to a situation like that. So this was a busy emergency list in a district general hospital. And on an emergency list, there's usually a team of anaesthetists working this type of theatre with usually a consultant along with a senior trainee, sometimes a junior trainee as well. And on this occasion, there was all 3 of them present. It's quite fertile grounds for trainees to learn from. And bear in mind, when I say anaesthetic trainees, they're not trainees, they're full-blown doctors who are specializing in anesthesia, completing a program usually to go on and become consultants in anesthesia. So when I say senior trainee, they've already done about 5 or 6 years of anesthetics and have probably got another 2 to 3 years to go ahead of them. So the emergency list is actually an excellent opportunity for trainees of every grade to learn and practice managing complications, patients, changing situations, that sort of thing. So this team were busy with a patient who was having something called a ureteric stent being inserted in theatre for a kidney outflow obstruction. The patient in theatre had a complex medical history, and both the consultant and the senior registrar were managing him in theatre. They were notified that there was a young patient who needed to have his appendix taken out with an operation called laparoscopic appendicectomy, so which means a keyhole surgery to take your appendix out. So they sent the junior trainee who had up to the ward where the patient was to do a pre-assessment on this patient. And part of the training for junior anaesthetists is to see the patient and then formulate a plan about how they're going to conduct the anesthetic based on the patient condition and the type of surgery required. So a laparoscopic appendicectomy, or a lap appendix as we call it commonly, is perhaps one of the most common operations in an operating theatre, in emergency operating theatres, and it's something you could call a bread and butter case for a trainee in anesthesia. It's quite good for them to actually try and learn to do this case as independently as they can, which holds them in good stead for their training. So When the trainee came back to report to the consultant, he discussed the case and made a plan to conduct something called a rapid sequence induction of anesthesia, also known as an RSI. Anybody with any sort of pain in the abdomen or potential obstruction in the gut has a risk that the stomach acid is going to come out. Very acidic stomach contents, risk coming up into the throat and then going into your lungs to cause damage to the lining of the lungs, leading to a lot of breathing complications afterwards. And this happens pretty much as soon as the patient loses consciousness. So to reduce the risk of something like this happening, we do something called an RSI, which is a rapid sequence induction. And like the name says, there is a rapid delivery of drugs one after the other. And before the patient loses complete consciousness, the time between the patient losing consciousness and a tube being inserted in the windpipe to block the tube so that the stomach contents can't go into the lungs is very, very short. And as this technique is very, very old, a lot of people still practice using the traditional drugs, which are a going to sleep drug called thiopentone and a drug used to paralyze your muscles and help to put in the breathing tube, and that drug is called succinylcholine. Now, thiopentone is one of those last remaining drugs in anesthesia which need to be reconstituted. So it doesn't come in a liquid form, it comes as a powder form in a little vial. And you dissolve it with 20 ml of water for injection, and it's 500 milligrams that you get in a 20 ml syringe at the end of the dilution process. To complicate matters further is an antibiotic called coamoxiclav, also known as augmentin, which unfortunately also comes in a powder form, also comes in a similar size vial, and is also diluted using 20 ml of water. Sadly, if you were to put two syringes next to each other, one containing thiopentone and one containing coamoxiclav, and you didn't label them, they would look exactly like each other. So because of this reason, to reduce the risk, the theatres in this hospital had a policy of storing thiopentone away separately from any of the drugs in theatres, and this was kept in a central drug storage in theatre recovery. When someone needed to use thiopentone, they'd go to recovery and go get it. So a couple of points about this. First of all, you could ask, how can doctors make a mistake between two such drastically different drugs? Under normal circumstances, no, you wouldn't. But that's when you have a clear mind, everything around you is running to plan, and there's no time pressure. Things are going completely to flow. But it's when there is a pressure of time and you've either dealt with something which is very, very complex, or you're a bit tired, you're supervising someone very junior, someone's trying to talk to you and distract you, and you don't want to be rude, so you go on and join them in their conversation and try and multitask, which in my opinion never actually works very well. Despite what people say about multitasking, I don't think the human mind is capable of something like multitasking. Secondly, for situations like these, when you think of the system as a whole, what the theatres have done here is remove something called a latent problem. Now, according to Professor James Reason, who is a renowned name in the field of human factors and designed the Swiss cheese model, latent factors are factors that are present in the theatre system inherently, and it gives you fertile grounds to make mistakes on top of the latent factors that exist. So if you kept thiopentone and coamoxiclav next to each other, it just makes it so much easier to make that switch and to make that mistake. And whereas if you removed it completely from the area, you theoretically reduce the risk of that switch happening. Now, you could argue that the biggest risk reduction in this regard here is if nationally there was a process to manufacture both the drugs in a completely different way and change the packaging. But that's the story for another time. It doesn't happen at the moment. So coming back to our scenario, because the thiopentone was stored separately, the junior trainee who was preparing the drugs drew up the water for injection in a 20 ml syringe, which he labeled with a yellow thiopentone sticker, drew up all the other drugs required, including succinylcholine, and he meant to go into theatre recovery to pick up the thiopentone, bring it back, dilute and get the drugs ready. But as he was leaving to do this, the pain nurses came down to speak to him about a couple of patients on wards who needed their epidurals reviewed and tweaked. And this sometimes happens when you're working on the emergency theatre. In fact, this is quite true of any so-called acute on-call person in the hospital. If you're on call, you're the port of call for a lot of different people, and it could be an acute medic, a surgical on call. The cognitive load, like we call it, is extremely high. So as it happened, this patient for the lap appendix came into the anesthetic room. The consultant stayed with the urology patient in recovery as they weren't very well. So they sent the senior registrar to come and do this case with the junior trainee. Now, as airway management is one of the most crucial skills to develop as an anaesthetist, what often happens in a case where there's two trainees doing it is that the junior trainee goes to the head end to manage the airway, and the senior trainee deals with administering the drugs. So this is pretty much exactly what happened in this case. The RSI involved it usually involves 3 minutes of breathing 100% oxygen, followed by a quick succession of administration of the going to sleep drug, in this case thiopentone, what was thought to be thiopentone, except in this case it wasn't thiopentone, it was just water for injection. So in went the 20 mils, in went the succinylmethonium, and succinylmethonium causes something called fasciculations, which is like jerky movements, twitchy movements all over the body from head to toe in about within 30 seconds of administering the drug. So that you see that twitching, that goes away, and that's when the patient's fully relaxed for you to do a laryngoscopy and put in a breathing tube. These two trainees noted that the fasciculations were particularly strong on this occasion, but anyway, they didn't think much of it at the time. They went ahead and intubated the patient. Once the endotracheal tube was in, they connected the breathing circuit to it and switched the volatile agent on, or the anesthetic gas on, and soon the patient lost consciousness. But they felt everything during the intubation because really they were wide awake and paralyzed and could not move. Now, let's look at some of the factors as analyzed by the NAP5 study. Not just here, but generally across the board when a mistake like this happens. In all of the drug errors, latent factors were identified in NAP7 and ranked quite highly as top reasons. Things like staff shortages, organizational issues such as disorganized lists, poor communication, rushing both by individuals and organizations, the pressure to finish a packed list on time, all had some role to play in mistakes overall relating to drugs. To put this into this context, there is a fine line between organizational pressure that improves workflow and pressure that actually impedes the workflow. So it's a bit like anxiety. A little bit of anxiety can heighten your performance, like before an interview, but if you get really anxious, you just stop functioning. There were many solutions proposed, but right at the bottom of this is the fact that we as anaesthetists understand and accept that we're human and vulnerable, especially when we're tired, hungry, irritated, with many different people trying to grab you for your attention, try and come and talk to you about something or the other. And this is particularly true if you're in charge of something or if you hold some kind of managerial responsibility within the department. So on the whole, how do anaesthetists prepare for situations like this? How do they build the resilience needed to act under pressure and learn to build the decision-making abilities that are required in their jobs? Well, there's 2 or 3 different ways in which this happens. The first is by rotating through a vast plethora of theatre lists in many different hospitals, which is what typically happens when trainees are in their training period across the 7 or 8 years that they train. They come across a wide variety of consultants, consultant surgeons, consultant anaesthetists, radiographers, doctors from other specialties, and so on and so forth. The act of learning to prioritize, adapting to multiple stimuli at the same time, communicating with several teams altogether, dealing with interruptions, phone calls, bleeps, changes in list order, equipment issues in the middle of the list. These are all things that we deal with right from the word go. And whilst you're relatively protected in the first few months or years of your training, your exposure to these situations where you are the front line dealing with the situation just increases as time goes by and you gain in your experience and seniority. The advantage, of course, is that you have someone overseeing all of this when you're a trainee. So you have a consultant who is right at the top who you can go to for advice or can guide you to deal with how the situation, and that's how most of the learning takes place. The second thing is the on-call system. So out-of-hours anaesthetists form a very vital part of the hospital team. They're involved in, we are involved with so many different areas of the hospital, and we form a part of the core areas, everything from A&E, resus to the cath lab, transferring patients out to other hospitals, cardiac arrests, peri-arrest situations where patients are on the brink of death. There's constant exposure to these situations. Again, the combination of mixing with different teams under stressful circumstances, new people in new environments, it helps so much in developing one's resilience. And finally, there's simulation. Just like pilots practice scenarios such as engine failures in the simulator, we practice situations like cardiac arrests and other emergencies during simulation. So, in conclusion, you are in very safe hands. Your anaesthetist of any grade will likely have undergone a tremendous amount of training and practice to deliver your care. The chances of you being aware during your operation are very, very low. Thank you for watching this video. In upcoming videos, I'll try and talk a bit more about some of the topics I've mentioned above. I will also analyze some more such scenarios where things didn't go to plan, and will try and break them down and go into them in further depths. Keep watching, and I'm looking forward to seeing you the next time. Bye-bye.